Welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we bring this podcast to you every Wednesday as a veterinarian, as a technician, as a dentistry team to help you be even better at veterinary dentistry in your practice. We're sponsored and partnered today with the Veterinary Dental Practitioner Program. If you're interested in being among the best anywhere in general practice as a team in veterinary dentistry, I invite you to request an invitation. Just go to ivdi.org/INV, like invitation, first three letters INV. So IVDI, International Veterinary Dentistry Institute, ivdi.org/INV, and we'll get you the information that you need.
Nancy writes, do you think a handout for the client to receive at drop-off about anesthesia risks and the procedure outline would help with anxiety clients going through when their dog is in for dental? What helps more is a conversation with the dental technician. And that can happen prior to admit. A lot of times when I was in general practice and I was pretty much the dental technician, and if we had a patient that is being recommended for a dental procedure, I would pop in and have a conversation with that owner, let them know exactly how the day goes, why we do what we do, and talk about anesthesia. And it's not a long conversation. It's very specific verbiage. We do our anesthetic protocols different for our dentistry patients. We are able to provide the pain management that allows us to keep those patients light, and most of my patients go home within about an hour after we're done because they recover so quickly, and we use those agents that metabolize quickly and provide adequate sedation, anesthesia, but appropriate anesthesia for a dental patient. And so it's very short verbiage. They're going to get that same answer. And so that kind of, one-on-one bond with that dental person or persons, if it's a couple of technicians, absolutely goes much longer way than just handing them a handout. And in a busy practice, I get it, it can be time consuming. You may need to be in 6 different places at one time, but it really will help with your client compliance and keeping those owners happy and coming back for those dental procedures. And we have to be successful at that, because if we're not, the only one that suffers is the patient. Because if they're not going to come back, we're going to be in the same boat a year from now, where they're going to be suffering in silence with disease in their mouth because the owners didn't feel comfortable or weren't educated to know that we need to see them on a pretty regular basis. Good question. April asks, what would be your butorphanol dose? 0.1 mLs per 10 pounds. And she caught me out in a little error here. You start out with 2% ISO and 1 liter of oxygen. And I apologize for that misspeak, but yeah, 1% of oxygen does not make any sense at all. It is 1 liter of oxygen. And so 2% ISO, we typically don't need to go over that. If I need to get my patient to a little deeper plane of anesthesia, if they're chattering, if they're moving around, I'm going to ventilate and really fill their lungs with that isoflurane and get them back down to a more manageable level. But yeah, we are talking about 1 liter of oxygen. Good question. Maddie writes, is it common to have use the same size sensor for all of your different dental patients? Yeah, absolutely. Tricks and tips. I would definitely get to a hands-on live dental radiograph positioning. A number 2 sensor I can use in everything from a 200-pound Irish Wolfhound to a 3-pound Maltese. And there are some nuances, there's some tips and tricks, but certainly hands-on and positioning. And when I teach live, I absolutely go over some of those tips and tricks as far as working with a bigger dog, working with a really teeny weeny dog to still make your views diagnostic. And it's a lot about troubleshooting and using that tube head to be able to get your x-ray onto that sensor, even if we can't get it to where we absolutely need it, primarily caudal mandible in those little teeny dogs. And there's definitely some techniques that you can learn in order to be able to do that with all of your patients. Alrighty, we've got time here for 1 or 2 more questions. Do you use hydro with torb? Again, the torb reversal effects, the torb is gone before my hydro, so I typically will still see them comfortable post-operatively and still sedate preoperatively as well. Marcia writes, I've noticed in the clinic I just moved to, a lot of patients don't breathe on their own. Would this be due to the pre-anesthetic or is something else a factor? Well, it depends on what you're inducing with. Propofol, when given quickly or too much, will cause apnea. And if those patients aren't ventilated, we can lose them right at induction. And so the pre-med, typically I don't have an issue with patients not breathing because of the pre-med. It's almost always due to induction and use of propofol. So I'm not sure if that's what's going on at your practice, but the rule is if they're not breathing on their own and you need to ventilate them, you need to turn off the gas. There should be no inhalant in the bag, in the line, flush all that out, and you're going to ventilate with O2 only. If we ventilate with an inhalant in the line, that patient is going to get way deep and we're going to lose them, especially if they're not breathing on their own. They're already too deep. We need to get them up, breathing on their own, and then we can get that gas on and move forward from there. So ventilate with O2 only in the line, take that bag off, flush, do an O2 flush, and then ventilate until they're breathing on their own. Kimberly writes, you did not mention anything about alfaxolone when going over your induction. We used to use propofol, but switched to alfaxolone a while back. Absolutely a great agent. It does have a really short shelf life. And in our practice, we have 2 offices, one in Orlando, one in Atlanta, and we're there once a month or once in every other month. And so because of that short shelf life, it's not as cost effective for us to use alfaxolone on a regular basis. So we use propofol, but alfaxolone in some of those other patients that dictate that would be a better induction agent. But certainly that is a great induction agent, and a lot of my colleagues use that on a regular basis. So absolutely okay to use that.
I hope you enjoyed that episode. If you'd like more information about the Veterinary Dental Practitioners Program, please submit to request an invitation at ivdi.org/INV.